Hi, I'm Siobhán Fletcher, one of the reporters up at Manx Radio. Welcome to this latest edition of our Newscast. Normally, we take you on a deep dive of Tynwald proceedings with our Tynwald in Brief recaps, but this time we'll be taking a look at what went on in the House of Keys this week. Yesterday, Tuesday the 31st of October, politicians voted in favour of proceeding with working on legislation which would help terminally ill people seek assistance to end their own lives. It means the bill will now move on to the clauses stage, where the finer details are hashed out. The move followed an extensive 6-hour debate, which Manx Radio broadcast in full. 17 members ultimately voted in favour, with 7 voting against. It was, of course, by its very nature, a divisive debate, and the first opportunity that MHKs had to discuss at length the main principles of the bill. I was listening across proceedings yesterday for our live blog, so let's have a recap of what happened. First up, Ramsey MHK Alex Allinson, the politician behind the assisted dying bill, took to the floor.
This process of debate, scrutiny, amendment and agreement is crucial to our democracy. It allows the public to see us making decisions on their behalf, reflecting their opinions and representing their views. The principle of this bill is that certain adult island residents who are terminally ill should be able to request specific assistance to decide when and how they might die.
Oncan MHK Rob Callister tabled a motion to have the bill referred to a committee of 5 members to consider and report back by the end of February. But given how long the debate went on yesterday, this has now been tabled to be voted on next week instead. In his speech, he highlighted concerns about what he described as death tourism.
I am concerned that the Isle of Man will start to see people moving to the island in the last 2 or 3 or 4 years of their lives, in order to take advantage of this particular bill, especially if the Isle of Man was to introduce this legislation ahead of England and Wales. That will certainly put a significant strain on the Isle of Man health and social care services. And therefore I feel one of 2 things must happen. Either we table an amendment to the draft legislation which changes the residency period of not less than 1 year to a residency period of not less than 5 years, in order to ensure that any legislation around assisted dying is for Isle of Man residents only, and to ensure that the island is not labelled as a death tourism location in the future.
Garth MHK's Andrew Smith and Daphne Kane had opposing opinions on their support for the bill, with the latter saying it was the clauses stage which would provide the proper place for debate.
I am sure that the Honourable Member for Ramsey and the mover of this bill will accept as a doctor that diagnosis, the process of determining the nature of a disease or disorder and distinguishing it from other possible conditions, is at best challenging, with prognosis, an opinion based on medical experience of the likely course of a medical condition, in other words, predicting the medical future, is an absolute minefield. I am not a doctor, but from my intimate experience through my wife's complex health issues over the last 30 years, I can attest to the fact that diagnosis is fraught with difficulties and prognosis even more so, verging on the nigh on impossible.
Mrs Kane also called on others not to compare this to suicide.
Comparing this with the suicide prevention strategy and suicides of young, healthy people, I fundamentally disagree with. Every suicide is a tragedy. Healthy people having mental health or other issues should not be conflated with assisted dying legislation to assist the terminally ill or to relieve unbearable suffering.
Arbury, Castletown and Maloo MHKs Jason Morehouse and Tim Glover appeared to share the same lack of support for the bill, with the latter saying there was no need to rush it. A sentiment echoed by Glenfaber and Peel MHK Kate Lord Brennan.
At least one positive to come from this process. The one reason why I can genuinely look Dr. Allinson in the eye and say thank you is because this process allows so many people to talk openly about the horrendous situations which they've experienced. From my perspective, that is a crucial point. Ideally, the Isle of Man decision makers must learn from this. Whatever the outcome of today is, end-of-life care on this island should be our priority. We are good, but we could be even better.
We're being asked to support something today which, if we're truthful, we don't know or have control of where it might end up. And that really worries me. We will be opening that can of worms The genie will be out of the bottle and will be nigh on impossible to put back. Members of this House change, governments change, and priorities also do. There will be cases that will be challenged in court, and maybe the following ensuing political clamour could lead to changes to the terms of what is undeniably a well-intentioned bill. We can't control that for the future, though.
The sense I'm getting is just say yes today and we'll sort out the rest of the detail later. It will go wrong and we won't be able to do it. So the best thing is to just say no to second reading today, and let's focus for the people of the Isle of Man on the things that we really need to do well and effectively and confidently.
In contrast, Douglas North MHKs David Ashford and John Wannenberg said whilst they had concerns about safeguarding in certain areas, this provided the opportunity to make progressive change.
A privilege, as we have in our grasp, the ability to progress the single greatest act of compassion that we can bestow. A responsibility in that we must eliminate any possibility of an injustice being committed through inadequate safeguards. This is too important to get wrong. The issues are deep and have already divided the island community. For many, this is a battle of heart and mind.
This bill is something that quite rightly ignites passions on both sides of the argument. Whatever decision this Honourable House ultimately makes, it will please or upset people probably in equal measure. While we in this Honourable House can't put ourselves in others' shoes, what we can do is ensure that any legislation is fit for purpose, and ours is the duty to decide if any such legislation is fit for purpose or indeed workable.
Dr Allinson's constituency colleague Laurie Hooper stood up to give his opinion, but he made it clear he was speaking in his capacity as an MHK rather than as Minister of Health and Social Care.
The Health and Care Service, including the Department of Health and Social Care and Manx Care, have taken a neutral position on this bill. This is primarily to enable staff to have the freedom and confidence to speak their own views openly without any concerns or risk of coming into conflict with any official view of the Health and Care Service. As such, the remarks I make today are my own views as a member of this Honourable House, not the views of the Minister of Health and Social Care, and I do not wish members to believe that I am speaking on behalf of anyone other than myself. Mr Speaker, I will be supporting the second reading of this bill today. I believe that fundamentally, people should have a right to determine how and when they might die when they are facing intolerable suffering, and people deserve the ability to have a compassionate and dignified end. This is not a decision that should rest in the hands of others. From my perspective, however, the main purpose of this bill is not promoting freedom of choice, but promoting freedom from or the alleviation of suffering. One of the core principles of this bill is that this choice around assisted dying should be available to people who are facing the very worst of circumstances, and crucially, that it is a choice the individual is able to make themselves. If you personally don't believe assisted dying should be an option for you, then quite simply there is no reason for you to access it. That is very much a personal choice, as Dr Allinson outlined in his remarks. Patient autonomy is a core tenet of this bill. I respect people having a strongly held belief on this issue, whether that's from personal experience or from deeply held religious or philosophical beliefs. Importantly, this bill would not impose a choice on anyone. Importantly too, we must not give anyone the ability to make this choice for somebody else.
Meanwhile, Aaron Michael MHKs Tim Johnston and Alfred Cannon were both split in their views, with the former acknowledging the difficulty legislators will have in ironing out the details of the bill, and the latter saying members should not be playing God.
One email I received from an individual opposed to assisted dying talked about the fact that we have developed a society based on the rule of law, respect for the rights of the individual, and compassion towards those facing difficulties. I would fully agree with that statement and would argue that is exactly why the principle of allowing an assisted death is the right course. If that weren't to be the case, where is the compassion in law when something like 600 terminally ill people take their own lives in the UK annually, but much more shockingly, several thousand fail in their attempt to end their own lives when terminally ill? Where is the compassion and legal framework for them? Individuals potentially left in an unbearable situation following an attempt, with their families left to observe and cope with further suffering. I think the island can do better. Where is the equality in someone having to find £10,000 to travel to Switzerland to end their lives, leaving their loved one who supported them travelling far from home and returning alone, likely to face an interview with the police? Or someone taking a month to die because they decide to starve themselves? Is the law, in this case, really providing all citizens with respect for the right of the individual and compassion towards those facing difficulties? I would argue that the law does in many ways provide that, but not when a dying person wants to have some say, some control of their last days. Mr. Speaker, in principle, I believe no one, however qualified, in medicine or theology, should have the right to ultimately do that. That, Mr. Speaker, puts a huge responsibility then on the law, on legislation. And that, of course, is where we come in. Everything I have said on this matter till now is based on my strong belief in the principle of assisted dying. Putting principle into practice is, of course, a different thing. That is why the clauses of this bill and all of the secondary legislation that goes with it will ultimately decide whether I believe principle can be put into practice.
Because by determining the answer to the question, can I legally end my own life, is yes, then in my view it matters not what framework is put around the circumstances. If we determine the basic fundamental right that you can legally end your own life, then who are we to judge in what circumstances that should be? Who are we to consider whether pain, mental or physical suffering is manageable or not? Who are we to judge whether or not you should suffer years of debilitating rheumatoid or arthritis or live with your serious disabilities? Who are we to judge that you can end your suffering without it having significantly impacted on you, but in the knowledge that it most certainly will? Who will we be now to judge who can and who cannot avail themselves of what is a right we are today only proposing to give to a select few? We will now have the potential to become experts in playing God with other people's lives.
A number of MHKs also raised their concerns about issues including safeguarding, saying that their votes further down the line will be dependent on certain protections being ensured. We're going to hear from MHKs Jane Poole-Wilson, Sarah Maltby, Anne Corlett and Tim Crookall.
As regards any future change in the remit of the legislation, it is not possible, as we all recognise, to bind a future Tynwald. But I think it important to fully understand the nature of laws in other countries where assisted dying is permitted, and also their constitutional position as compared with our own position. Canada has been mentioned a number of times, but Canada has a very different constitution to ours. And as I understand, the interpretation of their constitution in court cases has been the driver for the changes in the law they have seen. This contrasts, honourable members, with the approach taken by the courts in England and Wales, when challenge has been brought to seek the option of assisted dying. Judgments have made clear that the courts do not regard it as their role to step into this space, making clear it is a matter for Parliament, for legislators to address. The mover spoke about the different models of assisted dying legislation, and there are countries, predominantly in continental Europe, and my honourable colleague Ms Brennan mentioned the Netherlands, whose legislation extends beyond the terminally ill to those who are incurably suffering. However, in contrast, the experience in Oregon is that the legislation has, I understand, not been expanded, but has remained focused on assisted death as an option for terminally ill adults with capacity who have an expectation of no more than 6 months to live, with safeguards and annual reporting, which must include any misuse of the legislation. Honourable members, I feel that this does not have to be a choice between legislating to permit assisted dying in limited circumstances or protecting the vulnerable and safeguarding the availability of proper care. It is in our hands to legislate in the best way possible to achieve both, by framing the law appropriately with robust safeguards and then ensuring transparency and oversight regarding the implementation and use of such law. For me, introducing the option for an assisted death in the manner proposed by the bill is not about devaluing life. For some of the dying and their loved ones, it is about valuing a good death, and I support second reading.
Supporters of this bill have contacted me and said that this legislation should be brought forward as quickly as possible. However, I disagree. Urgency should not play a part in this incredibly complex decision. I am grateful for Dr. Allinson for his commitment to a staggered reading of the clauses, but I would like a further commitment of his intention to either move the House into a committee or at least support the option as we move through the clauses.
I stood for election to represent people because I care about people. I care about the people who desperately want this legislation in place. I have a friend who's facing terminal illness who is pleading with me to support. I care about the people who oppose this legislation. I understand their fears of how this could unfold for vulnerable people. As members, we are here to represent. I have to come to a decision. I have to press the red or the green button. When I first considered the issue of assisted dying, I was very clear in my mind that it was right to provide that choice. I would like that choice. I would still like that choice. But I'm between a rock and a hard place. I still support the principle of choice, but without amendment, I cannot support the legislation in front of us. I'm truly struggling to find a way through the dangers it may pose to others. I'm struggling to balance the positive with the negative. I do think it would be wrong for me to vote no at this point, because I need to support it to go further. I have to give the opportunity to amend this bill into something that would provide a person with the option of assisted dying, but would still safeguard the vulnerable.
And we've all heard some emotional stories today, and we've heard them out when we've been talking to people, and I do thank everybody for that, because although you think you know what you want, it's when you hear these stories it actually makes you think and question yourself. And again today I find myself questioning what I thought, I'd made my mind up. You listen to stories and hear, or tales, and you do question and think, how could that possibly happen? It couldn't possibly happen, but it obviously does. So we need to make sure. And that for me is one of the big issues that I have, the safeguarding part of this. It has to be right. If it's not right, if I don't think it's right, I absolutely wouldn't let it go any further.
Yeah.
Others made it clear that they believed these issues should have been already tackled by this stage, including Douglas MHK's Claire Christian and Chris Thomas, who said they couldn't support the bill.
I would feel more confident if this bill was picked up by the department and entered their legislative programme. We are to understand that this bill has been given Treasury concurrence, but could Dr. Allinson advise what business cases have been put forward to Treasury, if any? Has the full impact on Manx Care, DHSC, the police and the courts been included in the application of this bill? Could Dr. Allinson confirm what impact this service will have on our overstretched mental health services? Is there going to be provision in the mental health strategy to ensure that Manx Care will receive additional funding and resource in this area?
Hear, hear.
Furthermore, the General Medical Council currently does not provide training in this area currently. Could Dr. Allinson advise what discussions he has had with the GMC, how long they will take to create the protocols, the framework to delivering training to physicians, and is there likely to be an additional cost to the Isle of Man government?
But I do think it's really important at second reading stage to think in practical terms, in specific terms, and to be sceptical, and that's what I'm going to do. So I started this with Dr. Allinson, and full respect for Dr. Allinson for engaging about this, and I've subsequently been doing it with other people. But my first question is that has there been any discussion of a carve-out from the General Medical Council? Because we've been discussing that since the Brule Suite in April, May 2022. And I want to know very specifically, has there been any carve-out from the General Medical Council for the Isle of Man and other royal colleges as well? But we need to get to that situation, because it's very easy when it's presented by Minister Hooper in his personal capacity to say it's just a question of 4 regulations and a code, but the reality is that people who work here work in professional frameworks, regulatory frameworks which are British wide. So it being very easy here isn't an actual fact statement of the real fact. The real fact is it's pretty difficult because they work in professional frameworks. So for instance, instance, GMC guidelines, treatment and care towards the end of life, good practice in decision making on page 12, paragraph 10, following established ethical and legal, including human rights principles, decisions concerning potentially life-prolonging treatment must not be motivated by a desire to bring about the patient's death and must start from a presumption in favour of prolonging life. That's a must in there. And so disciplinary action could result. Has there been any discussion about a carve-out for the Isle of Man people who are subject to those guidelines? GMC guidelines on good practice in prescribing and managing medicines and devices, page 14, paragraph 106A. When prescribing an unlicensed medicine, you must be satisfied that there is sufficient evidence or experience of using the medicine to demonstrate its safety and efficacy. Is there such evidence and that sort of thing in these parts for that guideline to be complied with by the professionals who work here, subject to British Islands frameworks? Basically, and this is what I said back in May 2022, is it realistic for the GMC and the other royal colleges in healthcare, the pharmacists, the nurses, all the other bodies, to actually begin to change such fundamental things, as I put it then, and to provide a carve-out for our little island in the middle of the Irish Sea, surrounded by parliaments that have not yet gone as far as we will be going, it seems, with this legislation? Basically, there have been estimates of between 2 and 40 people using this annually in our island, and can we expect British healthcare frameworks to change just for that important number of us?
And the emotion of the day couldn't be understated if I tried. It was a charged debate, but one conducted respectfully, as noted by Speaker and Russian MHK Ewan Watson at the close of the day's sitting.
But can I say from my perspective from the Chair that today has shown the Keys at its absolute best. You've been thoughtful, analytic, caring and representative, and I don't think anyone on this island could expect any more than that.
Many members touched on their own personal experiences as they spoke, and how they've shaped their opinion of the proposals. Douglas East MHK Claire Barber was a nurse before being elected.
We will have talked about death more in the past few months than many people do in a lifetime, and for me, Mr. Speaker, that is a celebration in itself. Death is the final taboo, something about which most people are deeply uncomfortable, something said in a hushed voice, something to be approached with fear and uncertainty, and yet something we will all experience. Our house talks of death very frankly. It's a part of our lives, not by choice, but it's our reality. I overheard my little boys with a friend the other day playing on the PlayStation and chatting. Their friend mentioned that one of the game characters had the same name as his grandma's dog that had died of cancer. My 9-year-old son responded that his mummy had died of cancer. And they just carried on playing. A simple fact, a part of who they are, a shared experience. Death is a part of life, and one to which we should be allowed to exercise choice when choice has otherwise perhaps been taken away from us. In the vast majority of communications I have received, the need for compassion in death has been recognised, but there are differing interpretations of what and when and how compassion can be best achieved. As a registered nurse, I've worked in nursing homes, residential homes, intensive care, emergency department, hospice, and on the general wards, and I have been present at many conversations about death. With those for whom it has come too soon, those for whom it has come unexpectedly, those who've only started truly living when faced with death, those who are bereaved, and those for whom the suffering makes them wish death would have come sooner. I have always advocated for a good death, and I recognise that sometimes the concept of compassion is not one of prolonged life, but of reduced suffering. I have seen the amazing work those engaged in end-of-life care do, the care, kindness, honesty and compassion that are so needed as the conversation around death becomes a necessity. The advances in palliative care are to be celebrated, and I would not be advocating for an assisted dying law if we did not have an excellent palliative care service delivered primarily through our hospice. Assisted dying and palliative care are not an either-or decision. They are at times interdependent, yet they are distinct elements of autonomous care.
Meanwhile, Oncan MHK Julie Edge discussed her own deeply personal family experiences as a sort of word of warning to gathered members.
The Honourable Mover stated we have a 2-week cancer pathway. We miss that target quite frequently, and it's only an initial referral, not a 2-week treatment pathway, when people have had a diagnosis. We have a mental health service that is struggling to cope for our people. Same for dentists and doctors' appointments. Where will we be if a large percentage of our medical professionals consider leaving our island? We could decimate our island and the very purpose of this honourable court to protect and safeguard the people if we introduce this bill, which I can only call it the kill bill at the present time without all these safeguards. Do all honourable members really want to walk out of here today not knowing if we will be able to see a doctor when we require one? But we will be able to die with only 2 doctors. I have an autistic, non-verbal granddaughter whose parents could choose to make a decision about her. And as a grandparent, within our laws currently, I have no rights. We have too many pieces of legislation that are not right for our people socially now without introducing something that has seen overwhelming objection from the public. I've been a cancer patient. I still am. I've recently had further surgery. Honourable members, emotions change. People have different feelings and views. You have a diagnosis and you're told everything should be okay. But you never live one day without knowing if it's coming back and whether it's terminal. But you could make a decision and sign a piece of paper to not put your family through pain or yourself through pain. It's a roller coaster of emotions and we have no wraparound care for that. I was fortunate. I was in Liverpool. I could go to the Maggie Centre when I was at Clatterbridge and seek support. We haven't got that in the Isle of Man as yet. I'm hopeful that the cancer charities are bringing it forward, but we haven't got any of these services. Honourable members, I want to use this as an example of where paperwork can go wrong. This is a man in his 90s. In Nobles Hospital, and he was asked, did he want to live? He said, yes, I want to live till I'm 100. 2 days later, there was a sign above his bed, nil by mouth. I established why the nil by mouth was put above the bed. Struggling to swallow. It was literally said like that. Can you please explain what is happening? Keeps clearing his throat. Nobody had spoke to any family member to see if that was a normal condition of the individual. But within a 48-hour period, this man, who was my dad, was on death's door. I fortunately know he's a very quiet, unassuming person. And within a week, 10 days, his capacity got took away from him. Now, as a family, we had no say in that. He still has the same mental capacity today as he had when he was diagnosed with, I think it's classed as C001 Alzheimer's 5 years ago. Yeah, I can show you all, honourable members, what can happen when mistakes are made. and people's lives can be taken away from them. Not a choice of whether they want it to be taken away from them. So this is a medical certificate from the High Court of the Isle of Man, completed by a doctor within our Manx care. States qualifications, states about the patient, gives some background history. And then it goes to various questions for the medical practitioner to answer. It says there's multiple conversations documented in the medical notes. Who were these conversations with? A quietly spoken doctor that when an elderly person said, "Do you want to live?" probably no longer really trusts and doesn't perhaps answer in the way they would if a family member was present. No family members present when this happens. And this is my concern with any documentation that comes forward with this bill. But the point in question that I really want to point out of a mistake that can be made in our medical services is the patient visited by relatives or friends? No. Not been visited for 11 weeks. Complete and utter, absolute, wrong facts on a form that's taken somebody's capacity away. That could happen with any of these processes coming forward for this. That could happen with the two medical practitioners. We can't remove that. We could try and remove that now, but it'll be a lot of hard work and pain for family members. What I'm really trying to say to you, honourable members, we're here today going to make a decision on something to support people to die without knowing how it will be implemented, what safeguards are in place. If a mistake is made, where do people go? And I do find it quite shocking when we have situations that do happen, and we all know mistakes happen. That's why, as a family, we haven't addressed it to date. But it was devastating for my poor dad, who's now 93, in a nursing home against his wishes.
And Russian MHK Michelle Haywood invited the House to thank members of the island community who shared their similar deep hurt.
I'm sure you'll all have seen the impassioned article in the newspaper highlighting the tragic death of Simon Biggerstaff from motor neurone disease. I've known his wife Sue for many years and I'm proud to call her a friend. I commend her for speaking out, and I know that this has come at some considerable personal cost as she's relived some very traumatic times. And I'm sure the House would join me today in sending her our very best wishes and our thanks for speaking out in the way she has. What stories like Simon's teach us is that the current situation isn't working for everyone. It matters not what you think palliative care does or how hard you believe that everyone has a peaceful end of life, because this case illustrates that's simply not true. Simon was so desperate to end his own suffering that he requested the only option open to him, to refuse food. He asked his wife to leave the room. He asked the nurses what was keeping him alive, and they told him that it was the food they were pumping into him, and so he asked them to stop. He knew that it might take up to 30 days for him to slowly die, but he still asked them to stop keeping him alive. And Simon was utterly dependent on his wife and those nurses to follow his wishes. For him, if this bill had been passed, the euthanasia option would have been the only option, because if you can't feed yourself, you can't self-administer drugs you need, and you will need someone to help you do that. It's a sad but real fact that had Simon got sick 40 years ago, he wouldn't have made it that far. Peg feeding, keeping him alive, managed to get him much further down the pathway of his disease. But for him, the quality of his life was low, his pain levels unmanageable, and his life had become insufferable. He had no hope of recovery. And the only way to achieve his wish to die was to request to starve, for the nurses and his wife, who'd been caring for him so well, to stop keeping him alive. He had no other option. Perhaps this should call into question the constant drive in medicine to keep people alive. We use new technologies, new techniques, new medications, and always it's about keeping going. And we probably push that farther than we have, giving patients the right to decide what's happening with them. So as a consequence, people like Simon live further into an illness and survive longer than they would have done. And we have to face the fact that some people just don't want that option. There comes a limit where it's no longer viable for them. And we've ended up in a situation which allows patients to refuse treatment keeping them alive, but doesn't allow them to ask for help for a peaceful death. To follow on from the Honourable Member for Garth, sometimes modern medicine can actually cause the suffering by keeping us alive beyond the point that we can bear. There will be people for whom extended palliative care is the right option. But there will also be people for whom this is not their preferred option or even their choice. I spoke with one constituent whose mother was admitted to palliative care. She'd previously survived a stroke, but it left her confused and weak. COVID lockdowns didn't help, and although she'd returned home, it wasn't for long. She didn't eat or drink regularly, and she got sicker. My constituent describes it as she'd given up. After a visit from the doctor, she was admitted first to hospital and then to hospice. Her death took several days, during which she was prescribed increasing doses of medication. This was medication which the staff described as keeping her comfortable, and they told her family that the medication would hasten the end for her. I have to say that I'm struggling to see how supporters of the line that palliative care has a solution for everyone squares the circle on this one. In some cases, the palliative care drugs are administered with a clear statement that they will hasten the end. And I feel like there's some very thin legal ice underpinning some of this current practice. We already have the drugs that we need for assisted dying being administered by nurses and doctors in palliative care, just at sublethal rather than immediately lethal doses. And let's not make any allusions to that. I've been urged to reject this bill, which would result in exactly the same medications being administered, but in an open and transparent way, with a clear assessment of capacity and a prescribed process of consent from the recipient. That didn't happen for my constituent's mother. She didn't request more medication. The staff suggested it, and my constituent and her sister agreed in order to reduce their mother's suffering. There was no second independent assessment, no witness, no patient consent obtained. But I think it's really important that we acknowledge that that is not a new phenomenon. It's been going on for years. My gran died 40 years ago and had much the same treatment. Healthcare professionals have been doing this for patients, for many patients, over many years. This is the end point of palliative care. But sometimes it can take days for the patient to finally die. And I'm far happier to provide a clear process for a patient to request and consent to medication to bring about their own death and reduce their suffering, rather than relying on a kind nurse and a quiet conversation with my relatives when I am beyond expressing an opinion. Much as I love my 3 sons, I wouldn't want them to have to make that decision for me. I wouldn't want them to carry that burden, and I will make my own decision if the law permits me. In Simon's case, we recognise his right to refuse to be fed, in the certain knowledge that it would mean his death. But opponents of this bill will tell us that people like Simon shouldn't have the right to ask for medication to achieve that release a little bit sooner. It just doesn't make logical sense.
So you've now heard a little from everyone who contributed to yesterday's proceedings. The assisted dying topic is a subject that certainly divides opinion both inside and outside the island's parliament, prompting really difficult conversations wherever you may personally stand on the issue. So you may be wondering what happens next. Well, the bill will now progress to the clauses stage where some of the finer details will begin to be hashed out. The stage where Dr. Allinson hopes it will become our bill, with all members contributing and shaping the legislation. I'll give him the final word.
If I can just finish my summing up, Mr. Speaker, with her consent, I'd like to share with you the comments made to me by a neighbour who contacted me again last week. She said, "I'm 85 years old, and as death becomes closer, I dread the prospect of having no control over my ending. I can contemplate only the jumble of frightening alternatives which presently face the terminally ill. We can control our financial affairs through EPAs and wills. Surely a modern society should also allow us to do the same for the quality, dignity and timing of our death. Circumstances differ for everyone, and nothing is ever guaranteed, but should we not begin the process of bringing order to this area of life? It's only a question of giving people a choice. When my husband died in 1990, and it became obvious that yet more antibiotic injections were not working, I pointed this out to the doctor. His answer was that I was asking him to murder my husband and implied that my motives were financial. I don't know what action the doctor took, and my husband died alone within days, but I carried the burden of murder for many years until I found adequate counselling. Our teenage children had watched their father's steady decline and heard his pleas that we buy him enough pills to allow him to end the dreadful process. Surely we could do better than this. It seems to me that the safeguards embodied in the bill should be encouraged to protect the vulnerable. We should understand that there are other types of vulnerability, and she urged our compassionate action. Mr. Speaker, as I said at the start of this debate, it's an honour to be a member of this House and to advocate not just for the people of Ramsey, but for those across our community who are asking for compassion, choice and autonomy. I beg to move this motion in my name.
Honourable Members, the question I put is that the Assisted Dying Bill 2023 be read for a second time. Those in favour, please say aye.
Aye.
Against, no.
No. Division.
Division called. Honourable Members, the votes are 17 for, 7 against. The ayes have it. The ayes have it.